Okay, our next talk is going to be from Mr. Philip Hong, who is a fourth-year medical student at the University of Florida College of Medicine in Gainesville. And his paper is titled Structural Evaluation of Child Physical Abuse and Trauma, Social Determinants of Health at the Population Level.
Thank you for this opportunity to present. I have no disclosures. Child physical abuse presents significant morbidity and mortality to the pediatric population. Rates of child physical abuse have decreased only modestly since the mid-1990s, despite the increased focus on child protection programs. Risk factors such as age, sex, socioeconomic status, and psychosocial comorbidities have been shown to increase the risk of victimization, with the figure here showcasing the difference that race plays as well. Race has been linked to the structural elements of the built environment through zoning practices such as historical redlining and structural racism, which is increasingly being linked to health disparities. The built environment describes a structural element of where a person lives and presents a potentially modifiable element of the social determinants. The built environment has been increasingly found to affect surgical outcomes in both elective and non-elective cases, but it has not been adequately assessed in pediatric trauma, which is one of the most at-risk population within the pediatric surgery. We have used food access and social vulnerability index as proxy measures for the built environment. Food access, as defined by the USDA, as no access to a supermarket within half a mile for urban areas or 10 miles for rural areas, along with social vulnerability index, which is a composite measure defined by the CDC that describes the resilience of a community upon external factors. Thus, the aim of our project was to evaluate structural factors in relation to child physical abuse at the census tract level. This was a retrospective study from 2016 to 2020 at the only state designated level 1 trauma center in North Central Florida. We used our institutional trauma registry to identify patients with possible mechanism of child physical abuse. And we have collected social determinants using census tract data, which was extracted from patients' reported home address for geocoding. There were 317 children with reported child physical abuse. And among the abuse reported cohort, they were often younger with no significant differences in female gender. Patients with child physical abuse were more likely to have worse injury scores, such as Glasgow-Makoma scale and injury severity score, with their longer length of stay. This cohort also had higher proportion of Blacks compared to the non-physical abuse cohort. This cohort also had lower socioeconomic status, as indicated by lower rate of private insurance, lower family median income, higher poverty rate, and higher social vulnerability index of 1, which indicates a worse socioeconomic status. They were also more likely to be from an urban area with lower access to food, although this was not statistically significant. If combined of low income and low food access are analyzed together, it compounds the fact of the disparity as well. And surprisingly, only the low food access Black share was found to have a positive association with child physical abuse, while the low food access white share had a negative association with child physical abuse in our study. The conclusion that increased social vulnerability has increased child physical abuse reporting may not be earth-shattering, but it does affirm our hypothesis that place does matter. Where a child lives impacts the risk of child physical abuse. In our trauma population, patients presenting as a result of child physical abuse were sicker with with increased healthcare utilization, which we use the length of stay as our proxy. This significantly widens the gap of an already vulnerable population. Our study found social determinants like food access, poverty, and minority status are associated with increased risk of child physical abuse. And our study is not without limitation in that it is a retrospective nature. Along that, there exists a potential for reporting bias in which patients are referred for the evaluation of child physical abuse. Referral patterns are known to have racial and socioeconomic biases as well. Future steps include creating a more structured assessment of all social determinants of health within pediatric trauma patients, along with a universal screening for child physical abuse within all pediatric admissions. In addition, we hope to utilize geospatial mapping to better understand the built environment in relation to pediatric trauma referrals and outcome. Thank you. Thank you, and I'll take all questions.
Thank you. This paper is now open for discussion.
Max Langham, Memphis. Enjoyed this and really look forward to your work with the geoplots and the built access, which I think will be important. Although having grown up in North Florida, I'm not sure that that's a pretty bucolic little neighborhood. So you could come to Memphis and maybe get some better differentiation. My question is whether in your future studies of health disparities, you're going to include parental adverse child events. Because I think there's increasing evidence that parents who were victims of abuse or had adverse events are more likely to be abusers. And I think this would be an important cofactor in a lot of your analysis.
Absolutely. Thank you for that comment. We hope to create a structured questionnaire to provide to all patients that come into the pediatric surgery department, and that would absolutely be one of the variables that we can include.
Looks like we have a virtual question now as well.
Yeah, a question from the chat from Dr. Ian Mitchell. Given socioeconomic status, racial bias in choosing to assess abuse, how was abuse evaluation initiated? Following injury-based protocol or provider discretion?
Sorry, can you repeat the question one more time?
It says, given socioeconomic status, racial bias in choosing to assess abuse, how was the abuse evaluation initiated? Was it based on injury-based protocol or was it based on provider discretion?
Right, so within the institutional trauma registry, it was just for any suspicion or referral of child physical abuse. So there is not currently a structured guideline for how we have in place of child physical abuse. And one of the limitations is that we report the referral or the suspicion aside, and not the actual confirmed incidence of child physical abuse, which we think we can use in future studies to validate the data even more.
Do you think that that bias in reporting suspicion could have accounted for the difference you saw in between black and white association with poor food access?
Absolutely. I think, well, there are many factors in consistency with previous studies. I would say there is a bias. Some of the evidence-based screening guidelines that have shown reduction in racial disparities include working with child protective teams. However, they don't actually improve the rate of detection. They just reduce the racial biases that has been recorded. And it just increases screening to otherwise non-screened patients.
All right, we'll move on to the next talk. Thank you.